Thanks very much indeed. Some great, difficult to follow such great talks as those. Anyway, we're going to talk about complaints today, and this is what we're going to do. We're going to talk about the extent of the problem, the potential consequences of a complaint or an escalation thereof, some suggested management techniques to how to get around them and how to avoid them in the first place. I'm going to give you a couple of examples of real complaints. As Vabe said, the number of NHS written complaints is increasing. It was 150,000 4 or 5 years ago. It's now 174,000. That equates to 3,300 written complaints in the UK per week, which is 500 a day almost, which is a lot. It's not just a problem with the NHS in the UK. It's a worldwide phenomenon. Belgium, Denmark, New Zealand and Australia and the USA have all reported similar increases in written complaints. Most of these complaints are about the medical profession, and they're most by patients and their relatives, but some are from colleagues and some are from trusts. And if you get a written complaint from a colleague or a trust, it's more likely to be investigated. There's no actual national data available on verbal or informal complaints. So this is the sort of the tip of the iceberg. And I don't know about you, but our trust has got this brilliant system where if anybody rings up, the phone call is recorded, it's then put into text and then becomes a written complaint. So it makes your life even more administratively burdened. The complaints are mainly, about half of them, about sort of clinical issues. As Vabe said, about 12% of the attitude of staff, and all these here. You can see that even though we're only 5% of the medical register as surgeons, we account for 11% of the written complaints. So we do attract more complaints than our medical colleagues, or physician colleagues. In urology, we have about 1,400 people in the specialist register. We're the 18th largest speciality, so we do get a fair amount of complaints, but it's difficult to find out how many complaints we get, which I'll touch on later on. Is there a regional variation? If you live in the northeast, you're more likely to get complaints. Now, this has to be tempered with the fact that really we can't work out the data as to how many healthcare users or contacts there are. So it's just the number of complaints. It's very difficult to act as a denominator, to find the denominator. But obviously in the northeast and then London, patients seem to be more frequently complaining. If the complaint goes further, these are the reasons why people cite the requirement to take it further, and you can read those there. I tried to find out about urology complaints, so I emailed and had an email conversation with the NHS Health and Social Care Information Centre. They're very useful, but essentially it boils down to the fact that all written complaints are just grouped into 12 big divisions, and we're one of the divisions with all the general surgical specialities within it, so they can't drill down and find out the number of urology complaints, and they can't drill down beyond that to the number of genitourinary complaints. So essentially we anecdotally all think that andrology and GU surgery is more prone to litigation and complaints, which I think we all agree, but to try and actually find the evidence for that is very difficult. Julian may be able to tell you some more figures, but I don't think they're available in the public domain. In terms of surgery, it is an emotive subject. As Woody Allen once said, his brain was his second favourite organ, and certainly when you're dealing with male genitalia or even female genitalia, it's a tricky subject. And the counselling, as we heard, and the consent have to be done very carefully indeed. I think as you mature in your clinical career as well, one of the key parameters or key skills to develop is knowing when not to operate and when to actually, if the intuition tells you this patient is going to be potentially trouble and they have unrealistic expectations, is to have the courage to say, look, I don't think an operation is good for you, I'm not prepared to do that for you. You've got to keep careful records, and you've got to record erectile function and pre-op difficulties quite carefully. Stretched thoracic length as well as an indicator of erect length is sadly underutilised, and I think we're all guilty of that sometimes, thinking everything will be fine. It turns out not to be. You haven't written it down in the notes, and you're opening yourself to trouble. When I did quite a bit of general surgery before I did urology, and one of my bosses said this. He said, "Never operate on somebody you haven't at least said hello to beforehand." And I think it's a very good truism. You don't want to be meeting a patient for the first time when your registrar's cancelled them and consented them. You've done the operation, it's gone wrong. You're meeting them in recovery or on the ward, and you're telling them that something's gone wrong. It's a very difficult place to be in. Obviously, you can't always do that. If it's an emergency case, you're called into the obstetric theatre, you can't avoid that. But try and get a dialogue or a relationship with the patient before you actually operate on them. So pointers. We know that these complaints arrive usually sort of on a Friday afternoon, just before you're going away for the weekend. It's a fact of life. Try not to take it personally. It's a process. Try and distance yourself from what's happening and say, okay, it's part of my job. They're bound to happen. They do happen. I'll try not to worry about it. But nonetheless, they are a source of worry and anxiety, and it's a lot of paperwork as well. The most difficult ones as well, I think the transition from a trainee to a consultant also, is the fact that as a trainee, if you do something wrong, you get shouted at for it. As a consultant, somebody else can do something wrong on your behalf, and you'll get shouted at it. You get shouted about it as well. So it's very difficult, and the trust will probably keep a league table of how many complaints you've had as well. So, and how they interpret that is yet to be seen, but be careful of that. And obviously, these complaints can get worse and worse if you don't head them off. So how can you deal with them? Well, actually, sometimes complaints can be good. I mean, that sounds a bit strange, but actually, in the true nature of reflection, you can look at your practice and say, okay, should I have done something different? Could I have avoided this? You can change your practice as a result of it, or you can use it to say to your trust, this happened because we haven't got such and such, we haven't got chaperones in clinic, we need chaperones in clinic, we need more resources. This will help us to be better in the future. So they can be positive things, but often not. And also, I think, keep it in proportion as well, because in your dark days, it's quite nice to have fear of revalidation and appraisal, a big box or a file or electronic record of all the thank you letters you've got over the years and all the people who've been happy, and just read those when you're feeling a bit under duress and being battered by all these complaints. Also, if you do get complaints, it's good practice to put them into your appraisal discussion and revalidation, so that you're not accused then of ignoring them and keeping them hidden. It's a very good thing to bring them up and air them in your appraisal. I think if a patient takes the trouble to write a long letter of complaint, they're expecting a reasonably prompt response. But what they don't want is a quick letter dictated the day afterwards because you're angry and upset, and you send something that you might regret afterwards. So I would say obtain all the facts, take the time to obtain all the facts, but actually be mindful of the time ticking away, and the patient wants that response. Often it's gone through the trust that there's always been a bit of a delay before you get the complaint, so you just must be aware of that as well. Also, sometimes the trust will tell you that the patient's complained about something, but the details of what they're complaining about is a bit sort of obscure. So get the original complaint letter from the patient, even if you're only mentioned tangentially, just to see exactly what you're supposed to have done or not done. And then if the solicitor's involved, get a letter from those as well to see what their view is as why you have failed in their eyes. And I think the point is, address the issues sensibly, logically, one by one, no matter how spurious, and take it seriously. I find it helps to actually sit at a quiet time in the office, not in the middle of the busy working day, but perhaps at the end of the day, and just construct a timeline, either on a computer digitally or written. Just write out what actually happened, go through the notes, get all the pieces of information just to get it in your head. Because sometimes you find that you assume A happened before B, before C, but in actual fact, looking through the notes, B happened before A, and then C came around at the same time. So just have a look at that. And work within your trust mechanism. Don't stray outside that. If there's a well-worn path that you're supposed to follow, do follow it, and don't tend to write a letter to a patient telling them exactly what you think of them and not to bother you, etc. If you can head things off, a letter straight to the patient, telephone call, email or face-to-face consultation often gets you out of trouble. And if it's going to be a bit sticky, it's nice to have a witness there as well. In fact, I think it's essential to have a witness. And I find that if you tailor your response to the level of the patient's understanding or express concerns, that's very important indeed. Try not to bamboozle them. Once you've had that meeting or they've sent the letter, record it and make sure it's very clear. I've been in consultations with angry patients who've insisted that they had an audio recording, so we did that at their request, and halfway through they just started swearing and stormed out and slammed doors, and it was a brilliant piece of information on our part, actually. There's lots of people around, if you get a complaint, that can give you advice. Colleagues, mentors, medical defence unions, everybody. So if you feel that you want to get some advice, go and do so and use it. And sometimes complaints are easy and reasonable to address. These are there's 2 complaints I'll show you examples of. This was somebody for Peyronie's surgery, came to talk to us about Peyronie's surgery. And you can see in the letter the clues are, he's worried, he's unsure, he wishes clarification. He felt rushed during the consultation. It was a very long consultation, but he felt rushed during the consultation. He's worried, he wants clarity. It's not an unreasonable letter, it's just, dear doctor, I'm not quite sure what we said, I'd like to go. This was written before he actually had the record of consultation, which is sent out automatically, but he went home that day, wrote the letter, and then we had to answer it. So this is how I answered it. First of all, I said, I'm sorry. Yep, you're quite right. I'll address your points in order. There's no indication. The patient was obviously quite intelligent, used quite a well-structured letter, so reply in an adult and sensible fashion. And just basically saying, look, I understand you're worried. Don't worry about it. This is why we discussed it. I hope that helps. 2 weeks later, nice letter saying, thank you very much. I'm sorted out. I understand now. It's been a great help. That was one of the nicer ones. And you can put this in your appraisal folder, and it's where you've turned a complaint round to a positive outcome, and it's something to discuss with your appraiser. This is a slightly different one, but a complaint from primary care as a young patient, this 23-year-old, admitted with a 5-day history of severe left testicular pain. It had got better by the time he got to hospital. The FY1 wrote the electronic discharge summary saying that the diagnosis was a missed torsion, dead testis, sent out. The GP then wrote to me. I think there was a bit more to the story, in as much as the GP had seen the patient a few days previously, but he felt that the diagnosis and the stark fact of the letter was a bit harsh, which I could sort of see his point, I suppose. He had made a clinical error, he knew that, but he just didn't like the terminology and the wording of the discharge summary. So this is the letter we got, and then saying also that, you know, look, we have enough trouble in the healthcare business as it is, why are you making my life a bit more miserable? Which is fair enough. So we sent a letter back, just swallowed our pride and said, look, you know, this guy's really nice. He wants to be a general practitioner. He didn't mean it, any offence. He's an FY1. You know, yes, we recognise that there is a terrible environment we work in, and sorry about it, basically. The point was that he did miss the diagnosis, but we sort of glossed over that in the letter. So in conclusion, I think it's an emotive area, it's complex. I think you need to select your cases carefully, you need to counsel well, and you need to consent properly. I think in terms of consenting, I actually do somewhere in between. I don't consent them in clinic, but in the clinic letter I write out all the possible complications, send a copy to the patient and the GP, and then I do the consent on the day of the operation as well. So it's sort of belt and braces. They're becoming increasingly common, these complaints, so you need to handle them carefully. You need to be honest about it. If you had made a mistake, put your hand up, say, I'm really sorry, don't try and wriggle your way out of it, just be honest, duty of candour and all that. And if you are out of your depth and you feel that you need a bit of advice, seek advice, because I think we've all been through it and we all know what it's like, and we'll quite happily give advice on similar cases. I think keep in perspective, for all the complaint letters you get, there are many more patients you've seen who haven't complained, and are quite happy that you've done a reasonable job. Thank you.